A warm good evening, everyone. It's a great Sunday today. It's the fourth day of the International E-Conclave. Very interesting day because on the last 4 days we have been, since the last 3 days we have been speaking about a lot of things about pharmacotherapy related to tobacco cessation. So today we have the consensus whereby all the moderators from the last three sessions are going to present a short summary, and then we are going to have a great panel discussion with the topmost surgeons from different specialties across the country. Moving ahead, I'll just invite Nimesh sir again on the dais to please give the consensus statement for the evening so that we can derive some conclusions.
Thanks, Shruti. Uh, I'm, uh, I'm tempted to talk about two concepts that kept occurring through the panel discussion, and I hope our draft consensus statement will kind of take a middle road there. To me, it always seems that utopias are good to strive for, but with the reality context that utopias are essentially by definition not feasible, and zero risk options are very difficult. Let's begin with the format and participation that we have had in this 4-day conclave. You have had panel discussion from multidisciplinary groups, key knowledge partners, and of course you had the weekly quiz that you will possibly get to know the results of. Next one, please, Shruti. As you know, the themes that we have had are these on the left column. On the right column is what I have written down as I saw the relevance of each of those themes with the core team of ICanCaRe and other friends. Pharmacotherapy as the major plank, nicotine replacement as the pragmatism of harm reduction, multimodal approach as broadening the base for higher effectiveness, and review and synthesis for consensus that we are trying today to distillate and crystallize so that we can upscale. Now, some of us will remember on the day one, I had talked about the pizza base as the major plant, pharmacotherapy. Nicotine replacement, I see more as a pragmatism. Someday, if the household is not inclined to cook home food, which is of course more healthy, you order a pizza from out. And of course, the multimodal approach is more like those extra toppings that you might get at a discount. But what's very difficult, I've been thinking since yesterday, is my job to try and summarize for consensus statement, because this is like going to a large food court or a lavish buffet and deciding what to take on your plate and what to leave out. There's been so much said and so well in last 3 Sundays. In a lighter vein, let me also say this. Team, the definition of team. And I'd like to say, before I begin, I'd just like you to make it known that I did not volunteer to make this presentation. Actually, we all did collectively decide that I should. Next, please. Jokes apart, it's been an absolute pleasure and privilege to be part of the C-Conclave team 2021 with the core team of Dr. Pawan, Dr. Veena Kumar, Dr. Rakesh Rawal, Shruti, and Rishabh. And of course, the key resource persons that we have had, besides Dr. Swasi Charan and Jagdish Kaur in their capacities and whatever advice they kept giving, the three moderators for the first 3 Sundays who presented the summary today. And so I acknowledge the help from all of this really huge. Next, please. Let's try and go to the background to the conclave briefly. As you all know, it's a multidisciplinary entity, ICanCaRe, which has really done pioneering service and training activities, leading light for the conclave for sure. IHBAS as one of the leading academic institutions, which, like was mentioned, we started our tobacco cessation clinic in 2001. Before any other formal clinic had come. Well, of course, we heard Dr. Rakesh Rawal today leading the Gujarat University initiative. Many other organizations that Pawan mentioned and the pharma companies who supported us. Next, please. I also can't but help mention what I had mentioned on 11th July. Some of you will remember. There are 4 stages of group work described in a classic text: forming, norming, storming, and performing. And it seems to me that we did actually go through this pretty well, except that our storming was very nice and civil. But now is the time for us to perform, having performed, and see how our consensus statement can emerge. Next, please. The introduction and overview to the consensus statement, it would seem to me, will need to, with some data, mention the increasing pattern and frequency of tobacco use, and of course, the evidence that you have for India and South Asia was taken, that was taken note of. The fact that need for tobacco cessation programs need to be emphasized as part of the larger control strategies. Fortunately, that's been done in last 10 years and yet need much more emphasis. The bottom line being that the health effects of tobacco use leads to presentations across many medical specialties and health settings. That's been emphasized so well, as some of us knew earlier. That is the opportunity for tobacco cessation to increase the reach and the ease of implementation. And of course, what's been said in passing, I'd like to highlight, if you all agree, that tobacco cessation and treatment is actually need to be seen as one of the important prevention strategies. Every one person successfully treated prevents possibly thousands more. What are the important considerations? I'm glad it came up because we have had huge discussions with many national and international groups about this. That tobacco use pattern in India is actually very different. And if you talk about only smoking, you're doing actually such a disservice. And so what is used as a treatment strategy in some of the countries, smoke less tobacco. I don't even individually like to use the word SLT by now because that's a hugely misleading concept from the Western world. We need to recognize that we really must study all different routes, patterns of use, and the methods of tobacco cessation for those different routes. As we said, and as was said, in 2001 and 2, after IHBAS, NIMHANS, PGI, Chandigarh, a few others, and the Ministry of Health, WHO started the network of PCC services, uh, and the first 5 years data of that was shared in 2012 in the Zero Journal. What I would like to highlight is what has been emphasized enough in these 4 days. Low to modest quit rates if you really follow up long. Please register that and see if you agree. Next, please. Next few slides, I'm going to try and summarize the critical consensus points that have emerged on different issues. Quit rates are low, even in moderate term. If you long term, they are really low. The phenomenon of relapse is a harsh reality, like all substance use disorders, and needs to be dealt with and reckoned. The usefulness of pharmacotherapy for tobacco cessation has been mostly under-recognized and underutilized till now. You have monitoring mechanisms by carbon monoxide and cotinine levels if you really want to double-check the quit rates and the relapse. On pharmacotherapy, varenicline, bupropion have evidence for significant favorable effect. Of course, some evidence for SSRIs as craving suppressants in some cases with mental health issues. The evidence for effectiveness of pharmacotherapy is significantly in favor of varenicline, followed by bupropion as a general trend. Bupropion has definitely an edge. Just keep that for a minute, please. Yeah. For persons with tobacco use and depression or the depression linked issues. Next, please, should be. On harm reduction, the consensus that I gathered with my core colleagues is this, that harm reduction approaches for tobacco cessation need to be recognized as really as we know that quit rates are very low and abstinence-oriented approaches work in very small proportions. All harm reduction approaches deserve to be studied for usefulness and evaluated for their impact. Policies and regulations need to be open-minded and science-based for all HR approaches. NRT is a very useful approach, as has been said enough even today, although it may encounter some lack of acceptance and even resistance as merely replacement. Next, please. What's been alluded to today? Clinically supervised NRT is definitely the preferred mode, as we all saw in our discussions in last 4 Sundays. Amongst the NRT preparations, the evidence seems equivocal as of now, and so the person's choice and comfort needs to be combined with the clinical medical supervision for choice amongst different preparations. It's important, it came up very much, that clinicians seem to have their preferences about which NRT they would advise. And it seems much more sensible and desirable that we use actually the collaborative approach, discussion between the person and the clinical or the clinical team or the clinician. There are some indication people mention, and this is useful for our local Indian context. For people with oral chewed tobacco use and all the oral pathology complications, patches and lozenges would seem better. We again need to study this maybe more systematically. Next, please. For multimodal treatment that Dr. Mishra highlighted so well, many other colleagues said, there is overwhelming, almost compelling evidence for multimodal treatment providing better results and outcome, not only for I think or biobehavioral problems, but actually almost all health problems. The evidence for effectiveness of pharmacotherapy is significantly enhanced when you combine it with behavioral treatment strategies. Of course, some clinical situations may warrant combination of pharmacological agents with NRTs also, although that's a bit counterintuitive and can be debatable. This approach also requires multidisciplinary teams, and so no one or two professions can actually really be totally effective. Some more consensus points about multimodal treatment. Call them psychological, behavioral, psychosocial, call it what you will. These methods and techniques are useful in different ways at various stages, as I saw from the discussions. As a prelude to treatment, VBA, self-help skills. As an adjunct, CBT or RET, for treatment-resistant cases or multiple relapse cases. Of course, it deals with relapses specifically at a psychological plane. The trouble is that multimodal treatment and behavioral treatment seem to have this awe or fear amongst the medical clinicians, which we really need to overcome through sensitization and training, as Pawan has been saying again and again. Next, please. About multimodal treatment, the other thing is that we don't really know what combo works from the menu. In alcohol treatment, there has been this effort that clinically people still find appealing based on personality factors, nature of tobacco or alcohol use, medical comorbidity, treatment record, and relapses. You choose a certain combination for different groups of people. Did not come through as research evidence for alcoholism, unfortunately, through huge NIH research. And so we perhaps need to, while following the clinical intuition, we need to perhaps carry out research or at least wait for research findings to see if there are specific combos that you can work out for different groups and subgroups. Next, please. What about the service delivery points? As I've been saying in the 90s and 2000 and 2001, tobacco cessation unfortunately used to fall between two stools. Of course, the medical and surgeon colleagues thought it wasn't their job at that point of time. Unfortunately, many still don't, except for our enlightened colleagues who are with us today. Even amongst the mental health and substance use disorder specialist teams, it used to be thrown about between mental health and substance use disorder team. Now is the time, after this conclave and all the awareness that we have, to really see that this does not so happen. Only a few centers still really follow comprehensive tobacco cessation approach. Next, please. What are the benefits of multiple disciplines? Why should we be joining interdisciplinary teams? There is definitely the need for involving multiple disciplines for reaching far and wide. If you involve almost all medical and surgery colleagues, you'll have much more reach. But to me, much more important, as it also emerged from the discussions in these 3 Sundays and today, is that there's a lot of advantage in terms of acceptance by patient and family, continuity of treatment, the stigma being less, and the time, as our cardiology colleague said, the timing of the advice being right. Next, please. As I've said here, family physicians and many medical surgical colleagues which deal with health complications can actually join through sensitization and formal training. Of course, this will have to include, as has been said many times and today again by Pawan, skills, teamwork alongside follow-up care, technology use, and prevention of relapses. Next, please. As I just said, at least 3 definitive ideas besides the entire spectrum, like Rishabh said, 360-degree approach to technology application to tobacco cessation, like any other field. But these are the 3 that emerged through the discussions as we had. Next, please. For the action points and way forward, as I see and our core group saw, as we discussed yesterday and today, one, there is definitely a lot of need for uniformization of training, with, of course, some flexibility for regional and other variations through a modular approach to training. It will be very good for us and whoever other agencies with ministry, with WHO, Zero, and Nimans and others to say you develop SOPs for different settings and specialties. Obviously, it can't be one SOP for variety of settings. Clinical algorithms for common clinical situations. This has been attempted in last decade or so. We really need to perhaps improve on this. Cannot be overemphasized ever. Clinical and research work on Indian pattern of tobacco use, especially for usefulness and effectiveness of treatment methods for the chewed tobacco. What's also emerged in the discussion, especially last Sunday, is that there is also a lot of cases that come to especially surgeons and dental surgeons notice about non-tobacco oral chewing habits. There are a lot of compounds being used by our population, and should we be leaving them out at all? Again, there'll be the case of a clinical need falling between two stools. Next, please. I really am struck by how our thoughts go similar, because I saw in the discussions and individually in the last 3 or 4 Sundays that while there has been a huge negative fallout of the epidemic, it can also become a good opportunity in some aspects, and one of them is tobacco control, including tobacco cessation at all levels, macro to micro, advocacy and policy to enlarging tobacco cessation network, improving the services and uniformizing them, enhancing acceptance of tobacco cessation efforts by affected persons, and of course, enhancing public awareness and education about tobacco control, including tobacco cessation. Next one, please. There are 3 myths that I do want to talk about, and this came through in the discussions. Tobacco use is about smoking. It's a huge myth as far as India is concerned. A significant part of our tobacco use is actually oral chewed tobacco and indeed non-tobacco chewed products. So smoking cessation is an entirely misplaced concept. We need to only talk about tobacco cessation at every level of our thought. Next, please. The other big myth that bothers me is this, and this is one thing that we need to overcome through efforts of like this July 2021 and many others. That tobacco cessation requires expertise in psychiatry or mental health or counseling. Not really. Treating doctor, treating surgeon and physician is actually the best deliverer, or his or her team. Big 3 as I see. Shruti? Yeah. That total abstinence is the only valid goal. We need to really get more pragmatic and less idealistic, like we have done in large parts of medicine, healthcare, and psychiatry and mental health. And so harm reduction approaches, to repeat, including all options in harm reduction, be actually evaluated and be made available if found fit. I think I'll end there. Thank you so much. What we have said in our core group is that this draft and the ideas that have emerged today, any one of you colleagues, friends with us today, or any one of your other friends, if you'd like to send in ideas, modifications, criticisms, comments in the next 1 week, hopefully in the next 2 or 3 weeks, we should be able to actually have a draft consensus statement ready and circulated one more time for final review. Pawan, Shruti, I'll stop there. Thank you so much for operating the slides also, Shruti. Comments right now off the cuff are most welcome and will be appreciated.
Yeah, thank you so much, sir. And it's really wonderful the way comprehensively all the work that we have done in the last few weeks has been put together and so comprehensively put.